Hello, and thank you very much. It's so wonderful, Bex, to hear a patient and a professional talk to everybody and talk about their experiences from both sides. And I think that kind of brings me really nicely. I'm probably sit in between better and faster and the patient experience. Now, last time I came, I did ask how many people looked after children. And literally, oh yeah, I see a few hands pop up, more than last time. So I feel really positive about that. And for those of you that don't look after children, I hope I have some messages that I can share. So thank you very much for inviting me. And for those of you that don't know where Newcastle is, shame on you. It's the best city. We cover a very wide region from Cumbria to Middlesbrough, and we're a big tertiary children's hospital. And what I wanted to talk about is a tiny bit of why paediatric sepsis is different for those of you that don't know about children. And then something that I think Bex and lots of people have touched on, which is how do we recognize it? And not just how do we recognize sepsis, how do we recognize any deterioration? And finally, a little bit about escalation, because that's difficult. So 500,000 people are affected by sepsis, and half of those are children. And the majority of the children are under 5. But 75% of the deaths are in neonates, in babies. So sepsis is important in children. But what's really tricky, which I don't think you see in adults, is this is my problem. And this is a problem for anybody looking after children. Right? You're looking for Wally. So do you know where's Wally? Yeah, have you found him yet? By the time I've finished, you can tell me. So the problem with children is the first time you meet an infection, it could be a virus, it could be meningococcal bacteremia, you mount a huge systemic inflammatory response. So the first time a child gets a cold, they look like they're going to die. They get hot, they get tachycardic, and they are just lying in bed looking awful. And most of you give them some paracetamol and they pop up again. But in amongst that, there will be a few with sepsis, and they look exactly the same. And that is the challenge for paediatrics. So how do you find Wally out of that picture? How do you find that 1% with sepsis? And I want to put some numbers on that. So if you're in our emergency department, 30% of the children will have fevers, but only 10% will have serious bacterial infections. That means all the rest have colds and need to go home. But how do you know who to send home safely? Because in there is that 1% with sepsis. And if I go upstairs to PICU, 10% of their admissions and 25% of their deaths are sepsis. So I can't miss that 1%. So recognition of sepsis is difficult. And we know sepsis is a time-critical diagnosis, and that diagnostic uncertainty is more in children than adults. And they compensate better. So they're fine, 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 and then everything crashes. So the challenge of the early recognition isn't about treatment, because we know how to treat them. It's about the failure of recognition and escalation. And that's what I want to talk about, because I think all of you in the different places you will work will know where things could be better. And this is what everybody's been talking about, improvement. So the first thing is, this conveniently came out last month. So literally a month ago, the Surviving Sepsis Campaign Guidelines for Paediatrics had an update. Now, we've tried to use screening tools, and they were rubbish, because 40% of children triggered red flags, but I know only 1% have sepsis. So finally, they told us, stop doing it. Don't use those screening tools anymore. And that was actually really helpful. What they did say is, use the things that you have well. So think about your established protocols. Think about your early warning scores, so NEWS and PEWS. And we have really good evidence for this. So this is a big study of 11,500 children, and these showed you that all the 7 different Pew scores in the country, because we're all trying to become standardized, could pick up critical care admission. And it also picked up the deaths. But remember, that's very rare in children. So critical care admission's great, and it showed there was good area under the curve characteristics. So that's great. But remember, if you don't do any observations, you won't find any sepsis, will you? So I'm going to talk to you about what your pews looks like. This is ours. It's great. It's bespoke for us. It performs well. It's electronic. We finally made it off paper onto electronic, and I'm going to talk about that in a minute. We're also able to prescribe variances, which is really important because it allows us to be flexible for different physiological observations between patients, and that's important. And there was something else important. The NICE sepsis guidelines were also updated. And what they told us was something before really, really important. A lot of the time, the screening protocols just asked us to look at a set of observations, so that blue bar down the middle. So you just look at one set of observations. But that doesn't tell you much, does it? Because if I'm sitting in ED and all the children are hot and febrile and they all look like they're dying, I'll give them all paracetamol. 20 minutes later, 99% are tearing around the department, and all the parents are nodding here because you know what I mean. And they need to go home, right? So I need that bit of time. I need to see the trajectory with time. So you don't need one observation, you need this track. And when you see the track, it's really obvious how that, if you look at the top line, the respiratory rate was fine, 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 and then something bad happens and that patient goes off. So it's not about one thing, it's about a trajectory. And the other thing that's really important, and Beck's touched on this, is about families. We call it family and carer concern because a lot of our patients are too young to maybe vocalize how they feel, or only their parents will recognize it. Now, we have it embedded in our pews. We don't ask once a day. We ask every single time we do observations. And down the bottom, you can see it says family C for concern. So N is there was no concern, U was unavailable, so maybe mum was off at the toilet, and yes is yes, they are concerned, and I'll talk about that. But it's important, that's not once we've asked them, we ask them all the time. Now, I talked about variance, and this is really, really important, because otherwise, without variance, you get colour blindness. I bet you didn't know that. So this patient was one of our long-term patients who'd come in and out, and their normal temperature was 35, and their normal heart rate was 54. So that was both lower than you would expect. So if we didn't put in a variance, they would flag red all the time. And if they flagged red all the time, you couldn't see if they were actually deteriorating. So actually, you need this to make that specific for that patient, so we know when that patient is getting worse. The other thing we need is, we have all this data, we're now electronic, so we've got to use it. This is our compliance dashboard. And this is really exciting, because I can go in and look at any ward, at any time, at any day, and see how many observations they're doing. So you can see all those different coloured lines. The dotted line is our trust guidelines, so you should be over 90%. You can see some of the day case wards are managing that. And that yellow line at the bottom is the respiratory ward. And I don't really hate them for this. Actually, there's a reason behind this. They have a lot of long-term ventilation patients, and we don't have a variance for ventilation, so they trigger a lot. So it keeps telling them to do observations every hour, but this is a child who lives on ventilation, so that's obviously inappropriate. So there are specific problems, but it's really important, again, to look at patterns of use, and to think, where can we improve? So remember, data is power. We looked at time. And you know, in the day, we're really good at doing observations, 94%. And if you look at the times there, all the nurses go and do observations at 6, 2, and 10, because that's when you give medicines. So you might as well do the two things at the same time, which is good because you're not upsetting the patients, just going to them once. But it's bad because if they deteriorate at 3 in the morning, you haven't been there. And remember, all your respiratory illnesses often get worse in the middle of the night. So we did a little bit of work about this, and we went to the wards and we said, why don't you wake them up at 3 in the morning? I know this, you can laugh. And they said, guess what? The families don't want us to disturb them, and the patients get really upset and cry, and then they cry, and then they can't get a blood pressure, and then everybody's crying, and it's a disaster. So This is about what everybody's been talking about. It's about listening, it's about communication, it's about understanding. So we realized that many patients who come in don't know why we're waking them up. Why are we prodding them? What's that thing on your finger? Why are you squeezing my arm? So we did a really simple thing. As soon as you arrive in the wards, you see a poster, you get given this, and the nurses, your nurse, will tell you, this is the observations, this is why I'm monitoring you. And if you get worse, I'll do it more because that keeps you safe. It's not because I hate you and want to wake you up more. And actually, the parents were like, yeah, that's really obvious. And it was really helpful. So this is now every bed space. We also asked the nurses, so these are the nurses on my oncology ward. We went up to the oncology ward and we went, you're only doing temperatures. What about the rest? There are other observations. And they were like, oncologists only care about temperatures. You all know it's true, that's why you're laughing. So it wasn't really fever phobia, it was fever mania, that all they ever wanted to know, is it over 38? Is it 38.5? And then they're neutropenic, and then I can do things, right? So we did a very specific bit of training with that ward. We asked that ward, what can we do for you? So the nurses said, fine, we're going to make 3 times a day board rounds. We're going to stand at the board and make us do like regular observations. We're going to change the culture so we don't just worry about temperature. And please, can you educate the medics? Now, we all know the nurses are really good. I can see the man in the front's like trying to cry here. The nurses are really good at doing their mandatory training, and they listen and they learn. And the medics do the thing where they go like this until it's finished, and they never actually read it. So it was a really hard sell. It was a really hard sell to say to them, look, variances are important, observations are important, we can help you look after your patients. And I'm really proud to say that ward went from 50% compliance to our best ward. So it was really worth it, but it was hard work, and it was specific to them. And you need a stick, so you must have a policy. You cannot hold people to doing things without a policy. So we have a news and pews policy, but you have to have a carrot. So for us, we've got the ACE accreditation, that's the Commitment to Excellence accreditation. And this ward, because of their improvement in their observation compliance, got their silver ACE accreditation. So here they are, happy. So this is the end bit where I've just talked about deterioration and recognition of deterioration. So I've talked about monitoring compliance, using variants, embedding family concern. But you need somebody to do that, don't you? You need Pew's police. Oh, she's gone. This is Fran, who was here last year, our Paediatric Pew's police. And that gives leadership, and it gives a face to what we're doing. And she goes round to every single ward all the time to identify what it is that happens on that ward, because staff engagement is about ownership and culture. It's not about somebody coming in and telling you what to do. Oh. So I want to move on. So I've talked about the easy bit, right? The observations is actually the easy bit. The escalation is tough. It's complex. It's a wicked problem. And it's hard. And it's difficult because you need to know when to escalate, who to escalate to, how to do it in hours and out of hours, because they're not the same, and you need to do it for families and staff. So this is a really good start that the Academy of Medical Royal Colleges had this out, and this is great because it gives us some initial actions and timing. It tells us how often we should do things and who we should call. So that was a good start. The problem about saying you should call a certain person is it's not always clear who you can ring. And when it's out of hours, we all have colleagues who have really difficult jobs. So they might be in theatres and they can't answer their phone. So if the registrar's in theatre and there's no SHO because they're off sick, and the consultant's at home on a mobile that we know he doesn't answer because it's run out of battery or something, who do you call, right? So it's not about surgeons per se, but it's about people who have roles that takes them away from their phone, or in our hospital busy services, because then the ward staff might feel like, I know they've just gone off a little bit, but I don't want to bother you because they're already busy. So I think these are the sort of things we need to think about. And so we developed our personal hospital deterioration and escalation flowchart. And what that meant is it took the decision away and the uncertainty away, because the ward staff could say, actually, I'm going to follow this, and it's been half an hour and nobody's answered, so actually I am going to ring the reg, and the reg didn't answer, so I'm going to phone the consultant at home, because I'm just following this. It's not my fault. I don't have to make a decision. This is what I have to do. And this empowers staff to escalate. It gives them clear lines of contact. Ideally, in an adult situation, you have one point of contact, like a critical care outreach team, and we don't have that. But you can see we have made a special thing for surgeons because we know there's a problem there. So who can you get hold of? You can't get hold of them. This fits with our national pews. So this says the same. It also reminds you to think about sepsis. And the what to say can be difficult, because then you're on the phone, you might be on the phone to somebody you don't know very well, and it might be a consultant. We use this ISBARD tool, that's identification, situation, background, assessment, and recommendations. It comes from the US Navy. They used it on nuclear submarines for structured communication, and we've adapted it in healthcare. And that's been really helpful for people to think, what do I want to say quickly? And now I'm coming to the bit about family concern. And I feel really strongly that this needs to be embedded within this system. It can't just be a now and again thing. So it's part of our national Pews score. And you can see we ask a question, how is your child different to the last time I saw them? I mean, I could tell you that my child has just come back from holiday. They're really grumpy. They've got tons of washing and they're not speaking to me. And I would say that's slightly worse than the last time I saw them. So it's a nuanced discussion, right? It's not a yes, no, it's a nuanced question, and then you make an assessment of whether that's better or worse. It's important that we monitor this just like everything else, so you can see all the things within our pews, but that's one of them, and it's one of the ones that we found the hardest to encourage people to do. And we also want to encourage parents to talk to us, all right? And actually, you can't just say, oh, by the way, if your child deteriorates, can you let me know? Because what's deterioration, right? It's really hard. If we find it hard, it's even harder for parents. So this was the second of our posters, and we go through it with parents. So quite often you'll say, oh, my child's hot. But it's really important to remember things, just like Bex was talking about. Are they in more pain? Was there a change to their skin? Are they suddenly sleeping when they shouldn't be sleeping and missing feeds? These are subtle, and it's important that we know about them. And it's important that parents recognize that these are things they should tell us. I just wanted to compare a little bit to adults. So our family concern happens at every set of observations, and it's embedded in our pews. Yours happens once a day, but there are 23 other hours that you could get worse. I don't know what you do about that, but I do think that that's an issue. And I think the question you use in adults is more like, how are you feeling, better or worse compared to yesterday? And I think that's quite a difficult question. We need to think about health literacy and language and how people explain how they feel. This brings us back in a big circle to what everybody's talked about, which is Martha's Rule. And you all know these three components. So in pediatrics, the first one, we were laughing. We were like, that's what we're doing. And then we were struggling because we don't have critical care outreach teams, whereas you were the other way around. You were like, haha, we've got a critical care outreach team. We just get everybody to phone them, but you're not asking the first bit. So I think it's important to think about the three things and think about where you are in them. So we did start using Martha's Rule. We didn't have an outreach team, so our intensive care answers the calls. We do have 3 posters, not 1, because we don't think you should just call for concern. We also, I just want to say this, we hate the logo. It's not Mr. Martha, but that's another issue, because it looks just like Mr. Martha. So we actually say to parents, this is what we do to monitor your child, and this is what we want you to do, and you to come and talk to us about. And I think it's been really successful. So we're almost at a year. We've had 12 calls, and 2 were true deterioration. And the rest were a few complaints, some clinical communication. So not too many. And I believe that we have less calls than adults because we ask more often how you are. It is also because I'm sure there are more paediatric nurses. Like in adults, you've got like 3 nurses for your whole ward, so we probably have a better staff-to-patient ratio. And one of our parents said to us, we use Martha's call for concern. We were concerned because one of the doctors said, I think they might need to go to PICU. But then the PICU consultant came in and said, to be fair, I don't think they do just yet. And so we didn't go, but we felt that was a really big help. We got that advice, we stayed where we were, the patient was fine. So I think it's this really open communication. This has been our journey of implementation. It's taken us 10 years. The big round circles are the adult news improvements, and the little small ones are the pediatrics. So you can see how pediatrics lags. The 2 red dots were COVID, so we decided to go electronic just before COVID. That was great. So you can see how long, those 2 lines is how long it took us to implement it. And this is when we got our first deterioration nurse in 2024. So we do lag behind adults in terms of money, in terms of equity of resources, and that's something I always go on about. So, in summary, I just want to say sepsis in children is rare, it's difficult to spot, and recognition of deterioration is the core of good care. So developing a robust PEWS or news, thinking about the trajectory of deterioration, having variants to give flexibility, embedding families' views, thinking about your standards, your framework, and your policing. And remember, the police are a good community support. They're not always there just to punish. And this implementation is an opportunity for you to change. So thanks to Fran. That's my first thing. She's not here today. I'd just like to plug this. We have just finished writing the NHSE e-Learning for Life Sepsis Paediatric Learning modules. There's one for the acute care and one for community. All my nurses have done it, and they told me the community one, I know there's some GPs out there, 10 minutes. 10 minutes is all it took them. There are no weird tests in it, okay? And the hospital one, 20 minutes. So it's been, I really would like people to use it. It's also about resources. This is Healthier Together. I put this up on purpose. We use it a lot in our hospital. This says sepsis, and this is the red, amber, green rating, and I've done it in Arabic for you, just to show you that this is the kind of thing that parents want and need. I'd just like to say thank you to my amazing team, Melissa Burnside, Frank Kavanagh, who's been on all my posters. We do a lot of engagement with young people and young people's advisory groups and our disability groups in Newcastle, and I'm done.